Thank you all for coming. I'm just going to give a brief overview of varicose veins as a problem and some of the treatment options that are available. There are a few pictures that show varicose veins in sort of the advanced form, and some pictures from during surgery. So if you're faint of heart, just be warned, but it should be okay. About 25 million Americans will suffer from varicose veins and venous insufficiency. It's about 10 times more common than peripheral artery disease on the arterial side of the circulation. There's been a big improvement in the treatment options for varicose veins over the last 10 to 15 years. It's really changed the way we treat veins and has allowed us to sort of treat people with less severe disease, but still lead to a significant improvement in the quality of life. The old vein stripping procedures that you may have heard of has pretty much been replaced by the less invasive procedures. Again, I'll just give a brief overview of the history of varicose veins, some of the risk factors, talk about the anatomy and physiology and the pathophysiology, and go into how we do diagnosis and then how we do the treatments and the different treatment options available from in our armamentarium. This is a typical before and after picture of the bulging veins before treatment, and then this is after the laser ablation. You can see the veins have shrunk significantly. Just more before and after. This is just with using the laser as to treat the problem area. This is an old problem. The earliest known depiction of varicose veins is here from the Acropolis in the estimated 4th century BC. There's a lot of changes in the way we treat veins since the time of the Acropolis. But as I said, about 25 million Americans suffer from some form of venous insufficiency. That's more common in men than women, about twice as common in, more common in women than men, about twice as common in women, and it is more common as you get older, although it is not strictly a problem of elderly. See a lot of young patients that happen. It's mostly genetic that will determine when we see younger patients. Women frequently develop superficial venous disease during pregnancy, and that's probably one of the big reasons why it's more common in women than men. Men don't have the increase in the blood volume and the stress on the veins during pregnancy. It usually will worsen in severity in future pregnancies. So if it develops during pregnancy, it may go away, but then if you get subsequent pregnancy, it may get worse. And sometimes we develop the problem during pregnancy and it won't get any better even after delivery. About 50% of the population over 50 years old has some form of this disorder, and to varying degrees of severity. But as I said, it's not only a disease of the older. About 30% of people 18 to 39, 50% from 40 to 59, and 24% of people over 60. So it kind of happens gradually over life. The family history, as I alluded to, about 70% of people with varicose veins will have some sort of family history of varicose veins, and so it is predominantly a genetic predisposition. We don't really know why some people develop varicose veins than others, but it does happen when first-degree relatives also have the problem quite commonly. Talked about pregnancy and obesity as a risk factor, although it's only one risk factor, it's not even that dominant of one. And then lifestyle, if you're doing a lot of standing or sitting, that will put stress on the veins and can lead to problems over time. Although a lot of people may have veins, not everybody has symptoms. So if you notice that you have big bulging varicose veins, but you're not bothered by them, you don't necessarily have to do anything to treat them. But it is, to get a good sense of what the problem is, we do need to do a thorough evaluation, and we'll go into the anatomy a little bit here. So we're talking about problems with the veins. That's when the blood going from, after it's come down from the heart, oxygenated, goes through the muscles, sort of feeds the muscle the oxygen, and then needs to go back up to the heart to get reoxygenated in the lungs. So the veins problem is a problem of the blood going back up to the heart, and the artery is blood going down to the foot. And as we said, much more common to have a problem with the veins than with the artery, although both can be a problem. The deep system is responsible for about 85% of the normal function, and superficial system, which is really what is usually involved in varicose veins, is only responsible for about 10 to 15%. So you don't need the superficial veins to have a normal symptom-free leg, but if the deep system is involved, it can be more difficult to treat and can be more serious. So we'll do an evaluation of both of those. But it's the great saphenous vein and the small saphenous vein that are typically the superficial veins that are involved in varicose veins. As I said, the deep system is the primary route of return of blood back to the heart. It's supported by the muscles and connective tissue, and so when you're that's why it's often you have more problems with just standing still rather than walking if it's a venous problem, because when you're moving, the muscles are pumping and you're getting blood back to the heart. When you're just standing there, if the valves aren't functioning, that's when the blood can go backwards and lead to symptoms. The superficial system doesn't have as much support from the muscle and connective tissue, and that's one of the reasons why it's more prone to failure. And when the valves fail, then it can lead to pooling of blood in the legs and can lead to pressure and pain. Great saphenous vein or greater saphenous vein is normal diameter is less than 3.5 millimeters. It has some tributary veins, but it begins in the inside part of the foot and goes all the way up into the groin, where it joins the deep system. And there's some variations. People have duplicated saphenous veins and accessories. Short saphenous, or now small saphenous vein, is usually about 3 millimeters, and it begins behind the leg and just goes up basically up to the knee. This is when the valves are functioning normally, blood will go up, and when it goes backwards, the valve will close and it will stay there, and just sort of sequentially go up to the heart. When the valves start failing, you get this back and forth of flow, and when it really fails, that's when the veins will dilate. And when they dilate around, it will actually make the valves function worse. So it's sort of a self-fulfilling, or it will worsen as time goes on if nothing is done. As I said, the problem with varicose veins is typically a superficial vein problem, and it allows the blood to pool in the legs and not efficiently get back to the heart. In order to understand this, we need to know what veins are involved, and that's where ultrasound comes in. And the deep system, if that's involved, then it can be more complicated and lead to it'd be more difficult to treat. So how do we do diagnosis? Well, physical exam or history is important. This aching, burning, itching, throbbing pain, usually worse with sitting or standing, is pretty typical of a venous problem. If it's pain at night or in the morning, it's less likely to be a venous problem, although you can get cramping and throbbing pain right in the beginning of the night. So that's sort of after a long day of standing. If you first lie down and notice pain, that can be from the veins. But usually, if you're feeling pain in the morning after you've been lying, flat and gravity hasn't been working against the veins for the whole time, usually that's not the vein. That's the problem. It's something else. Can be at its sort of worst, it can cause venous ulcers, although most people never get to that point. And the symptoms can be exacerbated during the menstrual cycle. We'll do a history, not tonight, but if we do a full evaluation, we'll do a history to sort of basically to exclude any other cause for the pain, and to see if there's a history of prior deep vein thrombosis, which can play into that, into dysfunction with the deep system, and then whether it had prior surgery or any other treatment. The varicose veins can be progressive, can sort of start slow and over time worsen, but it doesn't necessarily progress. So some people have very similar size veins and for many years without problems. But there's also people that where the symptoms will progress. You can get to swollen ankles and inflammation, skin changes will go red and brown, and even, as I said, ulcers. So that's what we look for in physical exam. Basically look to see if there's any swelling, any chronic changes of venous insufficiency or venous problems. Look for pigment, redness, and then look at the type of the varicose veins. So this is what's more severe. You can see the bulging varicose veins here. But they come in different sizes. These are more spider veins. The veins of this size typically aren't big enough to cause real symptoms, but often people don't like the looks of them, and so they can be treated even for cosmetic purposes, but we like to exclude the problem with the larger veins before we do that. So we'll look at the veins and the legs to see if there's any problems in the connective tissue or muscles. Look to see if there's any swelling, and then make sure that the pulses are okay to exclude an arterial problem. We use ultrasound as really the biggest tool in our toolbox for diagnosing these problems. It's really changed the way we treat venous problems. And we're looking for reflux, so basically backwards flow in the saphenofemoral junction where the saphenous vein joins the deep vein. And this color flow indicates direction, and when it's going, we're seeing more than one color, that means it's going backwards. So when we're doing the ultrasound, we want to look to see what the source is, and that will really determine how we're going to do the treatment. You always want to start high and work your way down. If you start low and do the treatment, chance of the vein recurring is much higher. So you want to start high and work your way down as far as the treatment, and make sure you treat as high as the problem exists. And we do some size and check for reflux and sort of map out the whole venous system. And that's what takes some time. And we'll just do the screening tonight. Different therapies or options. This laser ablation is what we do most frequently here, although that's not the only thing we do here. Radiofrequency ablation is very similar technology. They developed at about the same time. At this point, there's not too much difference in their efficacy or side effects. It's basically just two kind of competing technologies that end up being very similar. This vein stripping, again, really no reason to do that these days, but I guess in rare cases it could potentially be considered. And then sclerotherapy and phlebectomy are sort of additional treatments we can do. Sclerotherapy, where we inject a liquid agent into the vein and will cause the vein to shrink and then over time get absorbed. And phlebectomy is where we do remove the veins through several small incisions, different from vein stripping because we're only removing the veins very close to the surface of the skin, so it doesn't require a big incision or big recovery. So the laser ablation, we can do in office with just local anesthetic, and patients can drive to and from the appointment and return to normal activities right afterwards. And you can see this is again a before and after, and this is before treatment, and this is with just the laser. These veins have shrunk significantly, although they're not completely removed. And sometimes we'll do a phlebectomy or remove some of those veins through some small incisions, just to make sure that they're gone after the treatment. But you can see with just the laser, they often will shrink significantly. Another before and after. Again, you can see the veins are still there, but there's the problem is higher up, so once we treat that with the laser, they shrink significantly. More before and after. So the laser ablation has been done since the late 90s. It was first cleared by the FDA in 2002, so there's now growing data of its efficacy. It's minimally invasive. We just use local, primarily done in the office, and has a high patient satisfaction, and it's safe and effective. This is one of the early papers from 2003, which showed about 98% success at 1 month and 93% at 24 months. So a pretty high success rate. That's comparable to the vein stripping, where even with surgical removal, some of the veins can recur. There is less than 1% chance of causing a deep vein thrombosis with laser ablation, which is again better than the vein stripping. Potential for infection or bleeding, and paresthesias. You can get some the heat from the laser can cause damage to some of the nerves that supply the sensation to the skin. It's not very common, and it often will resolve over time, but it is a risk of the procedure. This is just us doing it in the office here, marking out the vein with ultrasound, and then we do under sterile conditions. This is the laser fiber. We use ultrasound to guide the laser fiber into where we want to do the treatment, and we inject this anesthesia around the vein to protect the tissue from the heat from the laser, and then turn the laser on and pull it back, and that treats the vein from the inside. And then we put the compression stocking on and worn for about 10 days after the procedure. So again, after procedure, we wear compression stocking. You want patients to walk for at least 20 minutes, and do all your regular activities after the procedure. Just we tell you to avoid running and hot baths or vigorous gym workouts. And usually all you need is over-the-counter pain medications, not particularly painful afterwards. We have patients come back a week or two afterwards, check to make sure there's no problems at where we punctured the skin, no signs of infection, and we check with an ultrasound to make sure there's no signs of a DVT, or deep vein thrombosis. Then we have them come back at either between 6 and 3 months later and just check again to make sure the vein is closed. If it's closed at that point, chance of it coming back is almost zero. And then we can offer some cosmetic treatments afterwards once the problem has been the larger problem has been treated. You can get some bruising and a tightening sensation along the vein for a few days, and some mild tenderness. But as I said, over-the-counter medication is usually all that's needed. Just some before and after. I won't get too much into radiofrequency ablation. It's just something you may hear about. We don't use it here. It's just a competing technology. Initially, when they came out, there were some differences in efficacy and safety with the changes in the technology and sort of both sides. They're very similar now. So it's really kind of operator dependent. So just a different way to cause heat to the vein that causes it to close. Instead of the laser, they use radiofrequency. So you may hear about it, and as I said, I don't think there's any real significant advantage to one versus the other. From some of the earlier studies, this shows a less success rate, but I think the technology has improved, so they're very similar now. As in vein stripping used to be the gold standard, but the recovery was so much longer, sometimes requiring overnight stay, that and it isn't any better, so nobody really does vein stripping anymore. But you may hear about it. You have to make an incision in the groin and then actually place a plastic stiffener through the vein and tie the vein to it and then pull it out. So again, the recovery was longer, and it's kind of a gruesome procedure. So much less. The laser ablation is much less involved and much faster recovery. And sclerotherapy, again, is where we inject a chemical into the vein, and that will cause the vein to basically thrombose, shrink, and get absorbed. And then phlebectomy, not to be confused with the vein stripping, because it's just removing the veins very close to the skin, so it involves much less of incision and much less recovery. So in summary, the laser ablation is really new-ish, it's now not so new, but minimally invasive therapy that leaves minimal or no scarring and can be safely performed in the outpatient setting. It's an excellent alternative to the old vein stripping and has really replaced it for all intents and purposes. And it's a good treatment for a fairly common problem. All right, I think we're just about on time.